Thank you very much for the opportunity to speak at this year's STARS. I have no personal disclosures, and I think our funding sources for STAR were already discussed this morning, so I won't repeat this slide. However, I do want to acknowledge all of the members of my committee, and that is Michelle Hickey and I are co-chairing this committee. Annette Jackson, Alexander Senev, and Adoya Grimfarrar are also part of the committee. I feel very privileged to be a part of these discussions. I think we all have a good time discussing these things. And we've had mentorship support from Elaine Reed and Anita Chung, as well as statistical support from David Jerkson. Now, you guys have probably all seen this slide several times over the last few years, so I'm not going to go into it in detail, but just to remind you that in STAR 2022, we produced this summary table after reading through more than 60 different studies. And the take-home message that I think you've heard before was that there were really no clinical scenario where we felt that there was, grade 1A level evidence to recommend routine non-HLA antibody testing. And the reasons for that are partially summarized on this table. And what we said is that we need to have continued contributions and collaboration with industry, and I think you'll see why by the end of this talk. We also felt that we needed to improve clinical utility through standardization of our thresholds, and I'll talk a bit more about that as well, but of course you need to be able to have the same threshold across studies to compare them. We also need complete HLA typing and complete single antigen bead testing for HLA DSA to make sure that we are attributing the risk for these types of antibodies when we're looking at the outcomes of interest. And ideally, this would be done serially so that you know not only about pre-transplant DSA, but also de novo DSA that might be contributing to the outcome. And this is also part of what we need to find out when we look at multivariate models. We need to have robust sample sizes so that we have enough events and enough patients to adjust for confounders. And then lastly, we recommended the need for ongoing studies for discovery and novel mechanisms. In STAR 2025, we found an additional 35 new studies to evaluate. And you can see that 9 of these studies were either AT1R alone studies or the combination of AT1R with anti-endothelial A and anti-endothelin A receptor antibody studies. Interestingly, this time around, of those 9 studies, only 2 showed a statistically significant correlation with rejection, and none of the 9 studies showed a statistically significant relationship with EGFR or graft survival. You can also see that some of the focus of the other studies, there were 4 on GSTT1 antibodies. There were another there was 4 other studies that looked at using the commercially available non-HLA panels from one of the 2 vendors. Another small number of studies looking at just a small kind of group of different targets, 5 or 6 different targets selected by the authors. And actually the biggest group continues to be mechanistic studies or novel assays. When we looked at the sample size of the clinical studies this time, we found that the median was actually 100 recipients, and there were 3 studies that had greater than 150 recipients. Again, each of these 3 largest studies did not show an independent statistical effect from non-HLA antibodies with allograft survival. However, there were some significant effects reported for both rejection and other subset analyses. We were encouraged, though, this time around to see a lot more papers taking our recommendations to heart and reporting complete HLA typing, as well as complete single antigen bead testing for HLA DSA. We were also encouraged to see more consistent thresholds, particularly in the AT1R literature. However, this continues to be a challenge in some other areas, and I'll just highlight here. In 2022, there are actually 4 papers published focusing on GSTT1, and each of these 4 papers used a different threshold for positivity. You can see 3 of them were from one vendor using thresholds of 588, 1031, and 2914. And then the fourth study was from the alternate vendor who has, again, a different MFI threshold. So I think you can immediately see how this would be very challenging to compare one study to another or ever combine these studies in a meta-analysis. This is one of the novel mechanistic studies. I'm only going to show data from one of them in detail, and this is a study by the French group where they took a glomerular endothelial cell line and they genetically modified it so that it did not express class 1 or class 2 MHC molecules. And then they mixed those cells with patient serum in a flow-based assay looking at non-HLA reactivity. And what I think you can see here is that looking at 3-month biopsies, they showed that there was a strong correlation between non-HLA reactivity and glomerulitis, but this did not correlate with peritubular capillaritis nor C4d positivity. Because the correlation, though, was pretty strong with glomerulitis, you can see that MVI was still statistically correlated, as was ABMR-H, which was defined as the first 2 criteria of the Banff criteria. In a slightly different analysis where they just looked at ABMR-H-free survival, you can see the Kaplan-Meier curve on the left. And in the multivariate model on the right, what they showed is that if you had non-HLA antibody reactivity but no HLA DSA, there was a positive hazard ratio, but this did not reach statistical significance. If you had just HLA DSA without any non-HLA reactivity, this also had a similar hazard ratio that was significant. And if you had both of these in the same patient, that there seemed to be a synergistic effect with a hazard ratio much higher. And this is, I think, I brought this up because we also saw this reported in STAR 2022 with several authors making the claim of this synergistic effect. And it still remains a mystery to me. I'm not really sure if this is a synergistic effect from 2 different antibodies or whether or not this represents more severe ABMRs that are more likely to liberate cryptic epitopes and lead to non-HLA antibody formation. I think we need more study in this area because, as you know, ABMR just comes in one flavor. We don't really grade the severity of it. Just to give you a bit of other background, the other novel mechanistic studies that were reported are shown here. We saw several studies correlating non-HLA antibodies, not just with cell-based assays, but also other inflammatory cytokines, complement pathways, signaling pathways, several studies looking at different antigen expression in cell types. We had a paper correlating with other more traditional autoantibodies and a mouse model paper. But of course, as I think you can probably understand, when it comes to recommendations for testing, we're not really looking at studies that are just one-off studies in a single center and haven't been widely disseminated or validated yet, because I don't think those are kind of in early stages that we can't recommend for everybody testing as a group. So what we felt is summarizing the most recent literature in the intervening time period, that we did not feel that the new evidence warranted a change to our existing recommendations, and so the recommendations in that table I showed will stand for now. So the rest of the talk is going to be a bit different, and I'm going to switch gears, and so I thought I would put in a couple of cases here as a segue. I can't actually read this monitor because it's mostly showing the presenter notes, of which I have none, with the slide just in tiny little. Can you switch that? So I can see my slide and not the notes. That would be helpful for me because I'm getting old. My vision's not as good as it used to be. So this first case is a 67-year-old unsensitized male. Oh, that's so much better. He had end-stage renal disease from diabetes, and his PRA was 0, historically and currently no HLA antibodies. He received a transplant from an NDD donor whose KDPI was 58. You can see he was well matched for class 2, but not for class 1. And he received pretty traditional therapy with basiliximab induction, tacrolimus, mycophenolate, prednisone maintenance. And on post-op day 0, he actually came out of the OR with good urine output, or at least some urine output. But by post-op day 1, his urine output had tapered off and actually stopped completely. And so a biopsy was done to investigate. You can see that his G-score was 0, but he did have microvascular inflammation with a PTC score of 3. And he had a V1 lesion, and this biopsy was C4d positive. And because we could not find any HLA donor-specific antibodies by both historic or current sera using single antigen bead testing, we decided to reflex to the non-HLA panel. And that's what you're seeing here on the bottom of the slide. I've just put it in a kind of graphic histogram representation. And what I'm showing you here is anything that was any of the targets that were above the manufacturer's threshold are shown in red, and if they're below the manufacturer's threshold, they're in blue. And I've highlighted Perlecan and Vimentin just because they have been present in several publications over the years. And for those ones, I'm putting a green star where the threshold actually is, just so you can have an idea how far above the threshold it was. But I think you would agree with me that there are several targets here that are positive. Now, if we think about this in the context of BAMF, this is a situation where we do have diagnostic features of ABMR, and this is above the MBI threshold of 2, adding up the G and PTC score. And in addition, we have C4D positivity. So if you follow down the pathway, this means by both the old and current BAMF criteria, this would be ABMR. And what you're seeing here is this patient's creatinines measured over time. And you can ignore the y-axis on the left. That's in the SI units that we use in Canada. If you want to change it to American units, just take a 25% tariff. No, actually, sorry, that's a joke. Actually, you have to divide by 88.1, but you can see I've already done that for you. And the creatinine is there, 8.6 at post-op day number 1. And at that time, obviously, we have a patient who's not doing well. We have a biopsy that doesn't look good. And so he was treated aggressively with IVIG, plasmapheresis, and thymoglobulin. And you can see over the intervening weeks, he did much better. And by post-op day 22, we've got a creatinine of 2.0. And actually, on post-op day 41, he had a repeat biopsy that showed no inflammation, and C4D was negative. And so I think we all have anecdotal cases like this where we kind of pat ourselves on the back and say, okay, we found something. We weren't sure what it was for sure, but we treated it and it got better. And I want to compare and contrast that to a second case. This case has a lot of similarities. In fact, they only were separated in time by about 2 weeks. This is another older, unsensitized male, PRA 0. He also has diabetic nephropathy as the cause of his kidney disease. He received a DCD donor with a higher KDPI, but he was treated the exact same way. And on postoperative day 5, he still was not making any urine, and so a biopsy was done. You can see again, the biopsy in this case shows both glomerulitis and peritubular capillaritis, again with a V1 lesion. But this case, the C4D is negative. And again, with the best tests available, we could not find an HLA DSA to explain this inflammation, and so non-HLA testing was done. Again, you're seeing the same histogram here. This time, 10 different antibodies were above the threshold, and I've just highlighted Perlecan and proximal trends to eno-CoA reductase, as that's one of the antigens the French group I highlighted earlier has noted on several occasions. But you can see there's a lot of positivity here. Now, if we translate this to the new BAMF schema, we can see again, we have diagnostic features of ABMR. It is above the MVI threshold of 2, but we don't have C4D and we don't have a DSA. And so this actually is our new phenotype that has been named microvascular inflammation, DSA negative, C4D negative. And I think many of us over the years have asked the question, well, you just showed me on the last slide, the patient has 10 different antibodies. Can't we use these antibodies as part of our criteria to say that this patient has ABMR? And that's what this little subscript here, G, is referring to. And if you actually look underneath this figure, you will see a lot of text, which I will summarize for you to say that the BAMF group has looked at this and they actually recommended to follow the STAR guidelines and do proper DSA testing if you haven't done it already. And they mentioned that non-HLA antibodies in theory could be used, but at present no non-HLA antibodies have been, apart from ABO, have been validated sufficiently for inclusion, and they're literally just following our STAR recommendations, which is great. However, I think many of us have been in this situation. I know I have been in this situation many times as a clinician, where we're between a rock and a hard place here now, because we have a patient who is doing poorly, we have a biopsy that does not look good, and we've got now somebody telling us that there are antibodies in the serum. So what do we do? And I think a lot of people have reflexively said, well, just treat the biopsy. We don't know what it is, but it looks like ABMR, so let's treat it like ABMR. Interestingly, the reason I showed this case is because that did not happen, and the patient got better anyway. You can see that the biopsy time point here was on postoperative day 5. At that time, the creatinine was 7.52. The reason the creatinine is going up and down there is because they're still getting dialysis every second day. But of course, the testing for these, we first do HLA testing, then the non-HLA. It takes a day to get the biopsy read. And so while all of that was happening, the patient was actually struggling. He was an older gentleman who was not eating or drinking well. He was quite frail, and his urine output started to improve. And so we decided to hold off and do nothing. In fact, if anything, this person had their immunosuppression reduced, as it was felt the mycophenolate might be contributing to his poor appetite and his GI symptoms. So compared to the first patient, he actually had no specific treatment for ABMR. In fact, his immunosuppression was overall reduced compared to the last case. And yet by 38 days, he's doing a lot better. And on post-op day 43, his creatinine has come down to 1.53. So this, he has not been re-biopsied yet, as it was felt that he was doing too well to justify doing another biopsy. So this brings up a whole bunch of questions, I think, and I certainly don't have all of the answers, but I put this here to just highlight that we all have biases, and we all have these cognitive biases that have developed over many years. If you don't think you have a cognitive bias, that is your bias. But the reality is we've been talking about ABMR for decades, and I think we all know that MVI is an important finding. And we have to check ourselves when we think that an antibody plus MVI therefore equals ABMR. It may not in every case. We also have to ask the question whether all MVI needs additional treatment. Clearly this case did not, and this, as Michael mentioned a minute ago, there's real consequences to treating all of these. But I more or less put these two cases here to just open our minds and admit to ourselves, myself included, that we don't know all the answers, and we really do need to do yet a lot of learning. So how can we move forward? Well, one of the things that we've been talking about in a non-HLA committee is that we traditionally have been lumping all of these antibodies into one basket. However, there's many reasons to believe that it's much more complex than that. We know that we have both intracellular and extracellular targets. We've got autoantibodies, we've got alloantibodies. Some are persistent, some are transient. We've got targets that some are native and some are cryptic. We've got antibodies that are natural and pathogenic. And I would argue that we have to start compartmentalizing some of these things if we're going to understand that. And I'm happy to go further into that in the discussion if we have time. Another thing that we've talked a lot about in our subcommittee stems historically, the backstory is from the the ASHE in 2023. Michelle Hickey gave a great talk on non-HLA antibodies. And after that talk, several people came to the mic and pointed out that they'd been testing using both vendors' assays and getting slightly discrepant results. And after that meeting, we actually followed up with every single person that came to the mic and set up one-on-one Zoom calls with them to get more information and learn from their experience. And one of those people ended up joining our committee, Doya Grimfarrar, and her group in particular has gone a little bit further with this and has now have this publication that is in press in Transplantation. We know that there are 25 different antigens that are shared amongst these two assays. This figure is actually in the supplement of the paper here. It's not really the main thrust of the paper, but you can quickly see just by comparing the two assays that we are getting discrepant results. The other piece that we have noticed over time is that if you look at the vendors' thresholds, we know that they're defined by the mean plus 2 standard deviation. And when Adoya's group and Bloodworks Northwest repeated that process with 75 of their own healthy controls, what they saw was different thresholds. And here you can see in blue is the vendors' thresholds, and in red is the thresholds that I generated using data that Adoya was kind enough to share with me. And you can see that the thresholds they got were anywhere from 0.25 to 5-fold different lower or 8-fold higher. So that's a lot of discrepancy that I think should give us a bit of a pause. So this really comes to this idea of analytical validity. Analytical refers to the process or ability to systematically examine complex information, and validity, of course, is the degree to which a concept test or measurement accurately represents what it's intended to measure. Some of the things that we typically talk about with analytic validity are accuracy, and this is really talking about how close is the result to the gold standard truth. And then we can also talk about precision, which means how closely can we get the same result every time, whether it's accurate or not. You're all familiar with sensitivity and specificity, with sensitivity being the true positives divided by all positive results, so the true positives are false negatives, and specificity, of course, being the exact opposite. The limits of detection and range are kind of obvious what they mean, but I think it's important to point out that the limit of detection and range of an assay has to take into account the numbers that can be, the limits of detection that can be achieved without sacrificing accuracy and precision. That's the real limits of detection and range, and that's important. If you may have noticed on the slide where I showed you the thresholds, some of these targets have thresholds as low as 186 MFI, which for those of you who work in a lab will know that that's very, very low. And I think that's one of the motivations for several authors trying to reproduce their own thresholds, because they're not sure that they can accurately reproduce those types of thresholds. Lastly, robustness just really refers to can you have small little tweaks in the assay and still get the result, like for example, a slightly different temperature, pH, or even different person doing the test, and reliably get the same result. Why are all these important, and why are we really focusing on this in STAR? Well, I think the first reason is regulatory approval. Analytical validity is an absolute criterion for regulatory bodies like the FDA and EMA. Secondly is reliability for research and clinical practice. This ensures that the test provides reproducible results across laboratories and across time within your own laboratory. And third, these are the foundation for clinical validity. Without analytical validity, the clinical relevance of a test, whether positive or negative, cannot really be established. So for our committee, what we've done after carefully reviewing the literature, we've brought together 6 international well-respected labs, and we've decided we're going to share serum and test statistically what might be going on here. We're very grateful to the 2 vendors that have agreed to share reagents with us. And this multi-center international study has 3 main aims. Number 1 is to assess the inter-lab variability of both of these assays. Number 2 is to assess the intra-lab variability of both assays. And third, to compare the shared antigen statistically across both assays. Out of scope for the time being is lot-to-lot comparisons, serum treatments, or analysis of clinical validity. And you can see the labs that are participating in the bottom right. Just take a minute to say thank you to all of them for volunteering their time, as we've been spending the last many months trying to get MTAs signed between every one of these groups, as well as both vendors, which you can imagine takes time. This is my last slide. To summarize, I think one of the high points that I want to end on a positive note is that we really have seen that the quality of the data that we are reviewing is improving. We're seeing a lot of the recommendations that we made in STAR 2022 are now being routinely showing up in the studies that we are reviewing. However, there's still work to do, and I think we left STAR 2022, and those of you who heard the talks at that time probably sensed this, that at the time we really did feel, from reviewing the literature, that we just needed larger, better quality studies, or a higher number of good quality studies to help establish clinical validity. And you're probably getting the sense that this time around we kind of are taking a little bit of a step backwards and saying, maybe first we should really stick to analytical validity and make sure we have a firm foundation on that. And I'm happy to say that the last of the MTAs are trickling in, and so the results from this wet lab I just described will be forthcoming later this year. So I thank you very much for your attention and look forward to the discussion.
much. Chris, wonderful presentation as always. So happy you're part of this group. We're going to have the representative from this group to start taking questions, and Raj is up there. So,
Chris, so you talked about the head-to-head comparison from two different vendors, Werfen and one lambda single antigen non-HLA antibodies, and you pointed out there's not much correlation between two vendors on individual beads. That's kind of troublesome. So what is your take on that?
Yeah, I don't think it's maybe totally accurate to say that the correlation, I didn't give any numbers for correlation, although I have run those numbers and some of the little bit of data that Adoya shared with me. And to be honest, some of the targets have a correlation of around 0.7, and others have an R squared of 0.54. And so there are clearly some that are more highly correlated than others, but we don't understand why the correlation is low on the ones that are poorly correlated.
Yeah. So another quick question. I mean, if we're talking about, Dr. Kumar is on the table. So the quality control, we don't have a proper control. So each bead, there's no quality control to cover all the beads. So is there any progress to work on to get those quality controls? Oh, okay, there you go. Answer there.
My God, we're right on the same wavelength. I was going to say the same thing. So I have to say there's a parallel workshop going on that's lost in the MTA world as well. And it's being organized by Carrie Butler, Michelle, myself, and another set of very distinguished laboratories. And what we set out to do, we spent a couple of years on doing this. We have been procuring reagents. So it's the opposite. It's testing the targets, but it's reagents that antisera from pregnancy mostly, but from transfusion medicine, we've been obtaining these. We've been screening them on the panel to identify a resource of sera that can actually be used to standardize the panels. Because, in this case, it hasn't been done. And we've been working with Werfen, and we have a collaborative going on with about 6 labs, I think, as well, similar number. With the whole idea in mind is we can't move the field forward unless we have reagents to standardize amongst all the laboratories. So our goal would be, if we can get this, and get the data, we're going to publish the paper, but really to share the reagents through the UCLA cell and serum exchanges so that they would be available worldwide. And we would have a system of send-outs. And that's kind of the big picture. We're anxious to get started. It's a similar situation, kind of lost in the MTA world, but it's a critical missing factor in the field without standardized reagents, and this has been our goal. And so I just wanted to kind of share that with the panel, and thank you for setting the stage for that question.
Yeah, quick comment. So we have been using Werfen reagent to look for this non-HLA antibodies. What we found is you can see the women with the multiple pregnancy have more non-HLA antibodies compared to the men. Then the retransplant candidates make more non-HLA antibodies compared to primary transplant. Then African Americans make more non-HLA antibodies. Then the patient with the IgA nephropathy make more antibodies. So maybe we need to, combine these individuals like a female retransplant candidates, African Americans, and IgA nephropathy. There, you may cover most of the beads, in my opinion. So I think we need to target some of those.
Yeah, no, it's a really good point, because the ones we get from transfusion medicine obviously are the ones that aren't going on to be used for platelets, as you can well imagine, because of trolley. So they're the multiparous women, so that's our source. It's very interesting you bring that up. Yeah, let's talk on making sets of reagents. Thank you, Raj.
If I might just add one more thing.
Sure.
Okay, thanks. I just wanted to also add on to this topic about like QC of reagents and standardization of reagents, that as users of the tests, we are in fact blinded to the differences between the tests. We don't know if the proteins that are on the beads that are shared between the two vendors' platforms are sourced from the same place or if they aren't. And so this could be another one of the reasons for discrepancy between the two tests. In addition, I imagine, I have more experience with the warfarin product. My colleague has more experience with the 1-lambda product, but the background on each bead individually in between the two tests is also different, which can also lead to variability. And so by using standardized reagents and sending out serums like we're doing, we're hoping to gain more understanding on how the beads may even be improved through our findings of these studies.
I want to say before we're moving on to the next question, first and foremost, thank you for the vendors who provided us with those reagents for no cost and really supported this and had been very, very transparent with allowing us to do those analysis. What I want to add is that there's a lot of pressure from the field, and I'm going to put it on all of you for a minute. All of us want the next kid on the block. We want a new assay. We want it fast, and we're putting a lot of pressures. Of course, the companies need to satisfy their investors and so on and so forth. But I think we need to work together to get to a point where we have really good quality kits to work with. We've seen this in HLA. We're seeing this now in a lot of other fields, and yet we're seeing lots of new companies coming up with new products to the field that everyone is trying to use and get reimbursed for. So I really want each and every one of you to think about it as you're planning your next clinical endeavor of doing things, and let's try to make things right before we jump for everything else. Yes, there are a lot of things that we need to improve, and we need the community to help us do this. We need the collaborations with the vendors to do this as well. Hugh, I think you were first.
Yeah. So Chris, this is wonderful talk. So I have two comments to make. One is regarding difference of those two vendors. In fact, we test huge, like close to 100 zero in 2020. Compared to two vendors, they're different. I present my data to both vendors. So that's it. So there's nothing happened from that. So we didn't publish the data in it because we think it's going to be very negative to the community. So this is number one. Number two is I think there's two parts of the question regarding clinical validity. One is regarding negative control. What is good negative control? Another one is what is positive control. Because we not only face the vendor versus vendor consistent, there's lot there could be a huge difference. In one vendor, the difference seems much bigger than another one. That one specific vendor seems like their threshold never changed because I use their kit since 2017. They have never changed their threshold. So I agree with Annette. We need to help them, and I think at least they should. Another vendor seems better because for each lot, the rerun thresholds are different. It's rather more consistent. So and to check consistent, we need good positive control. So without good positive control, you have new lot coming. Even you rerun negative control, you whatever threshold you use, and it's not compatible because you don't have a positive control there. So as for positive control zero, I think the community need to help the vendors to contribute a positive control zero. So that is regarding this assay. So I would just like to comment regarding your two cases. I think we have seen cases we follow treatment in heart transplant recipient. I have seen some of the target reduce, the others don't change. I think we need to get into the part that's two different explanations. One is the beads won't change, could be non-specific reactivity. Another one is there are organ-specific targets there. Like for arginine, I never see this one in our lung cohort, and what we found in lung cohort is different from you say published in heart cohort. So I agree we need to talk about different compartment. expressed, but in the end, we have to use on each different organ setting. Thank you.
Yeah, I'm going to make a few comments there because you brought up two important things. One is that if you just think about this idea of using the mean and 2 standard deviations to determine a threshold, which is what we're stuck with right now because of the lack of an alternative positive control, it's kind of problematic. And I say that because if you just think about how we determine normals in medicine, if we wanted to determine the normal serum sodium for everybody in this room, we could quickly check everybody's blood, check the serum sodium concentration, we get a very narrow range, and we could take the mean and 2 standard deviations, and that would make sense. But when we're talking about antibodies that 80% of people don't have, and you're taking the mean of those numbers, you're comparing 80% of the people with zeros compared to other MFIs in the rest of the patients, and then taking the mean of that value. So that's much more problematic. And so I totally agree with you. We need a different way of having a threshold or a positive control that we can rely on. The second point is another thing that you said is about compartmentalizing the antibodies. The reason I said in the talk that I felt that this was necessary is if you can imagine a thought experiment where we actually said that right now both of these assays were perfect and they were approved by the FDA, the analytical validity was excellent. The next question is, well, does any HLA antibody then help us make the diagnosis of ABMR? So for example, if you had a patient with MVI and one of these antibodies positive, is that helpful? And I would actually argue the answer is no, it's not helpful. And the reason is everybody has antibodies. And where's my evidence for that? Well, if you look at the Leuven paper with Martin Nasons and Alexander Senev as the first author, they tested the biggest cohort yet of 900 plus patients, and 98.7% had at least one target positive. So if only 1.3% of the patients have no antibodies at all, then the test is useless. We can just assume it's going to be positive, and everybody who has MVI is going to meet the criteria. So we have to know more about which of those targets are important and which are just bystanders and don't mean anything.
If I could, because I was thinking a little bit about this, especially after having the NK talk, it would be interesting, I think, what it would be like in our field if we knew all of that. Would we even be getting into this whole non-HLA antibody space? I kind of wonder that. I also wonder about these non-HLA antibodies. You had that slide where you showed they all have different places. Some are intracellular, some are extracellular, some have to do with cytotoxicity and different mechanisms. How would they look different on the biopsy? We know in nephrology there's a lot of different antibodies, but they look different. Their pathology is different, and has that been explored?
May I?
Yeah, please.
Carrie, I want to answer your first question, and I want to say the answer is yes. And the reason that I think the answer is yes is because the equal and opposite question is also true. Mm-hmm. If a test for SERP1 alpha or a test for non-HLA, if either one of those showed great indicator, would we study the other? Yes, because we're still interested to understand how these different systems work together to combine or contribute to cause graft injury. And I just think that there's so much more here than we currently know. We're still at the very beginning of this. It's a very difficult journey. And back to your response before, if there was one antibody positive, was it important? Versus if there's a breadth of antibodies positive, which we showed in our heart transplant paper, and which Alec also showed in his paper, and I believe it's been shown in a few others as well, the breadth of sensitization appears to be more highly correlated with poor outcomes. And so I think that that could be something to help us define or redefine how you determine what's clinically relevant or not.
I just, I want to say what everybody is saying in a very reductionist way, and something maybe that's kind of provocative, which is these assays are multiplexed for convenience only. There is no scientific reason to have a test that measures antibodies both to a chemokine and to a cleaved product of the extracellular matrix, except that it's easier to put it into a multiplex test. And I think what we need to do is step back and recognize exactly what Chris is saying, is that each target has its own unique biological properties and its own data behind it, and then it was thrown together into a test. And I think when we're going forward, trying to translate, once we have the analytic validity, we can measure antibodies to each of these analytes, and that's established. The clinical validity, the relationship of reactivity to that analyte, and rejection or MVI, it needs to be tackled analyte by analyte. We're talking about an assay, but it's really a collection of 40 different targets. Some of them are going to be irrelevant, some of them are going to be bystander, some of them are only going to be pathogenic with a second hit, which, Chris, your example of the patient who received a KDPI of 90, kidney transplant and had strong perlecan antibodies, maybe the perlecan antibody was pathogenic, but it wouldn't have been a problem if the KDPI was 20. So I think we need to look at each of these analytes individually, even though that magnifies the scope exponentially, instead of thinking about a whole assay and is it valid, yes or no.
Yeah, thank you, Nicola. That's an excellent comment. And I hope you guys didn't think that by me giving that case, I don't think any of these patients need treatment or that those antibodies couldn't be playing a role. I totally agree with you. I think that, I have theories upon theories, but I can't prove them. But it's quite possible that some of these antibodies are there for years, if not decades, in these patients, and only in the right environment do they become pathogenic. And in transplant, we have a very unique situation where we're exposing the immune system to an organ that hasn't had any blood flow, is at a totally different temperature, has ischemia reperfusion injury universally. And in that situation, those antibodies probably do have targets from necrotic cells and apoptotic cells that aren't necessarily there all the time. And I do think that they could contribute to the C4D positivity and the MVI that we're seeing. I just don't think that we can take the next step and equate that to what we know from 2 to 3 decades of research about HLA ABMR and assume that we're going to have to do the same thing to treat it. And I think we have the potential to actually harm patients if we assume those things and treat the same way.
Yeah, I'm David Cohen from Columbia. One dumb clinical question. In the patients when they got better, the patients who had the non-HLA antibodies, did you retest to see if the antibodies were still present when the kidney had recovered? That was one question. And the other, following up on what Nicole said, is what do we know about the expression of the targets of those antibodies on the kidneys?
Yeah, good question. The answer is what we routinely do when we're testing for non-HLA antibodies in our center is we always test pre-transplant and current serum whenever that biopsy is being done, but we haven't at this point done follow-up testing. I can tell you that there's a lot of interest in this, particularly Ian Gibson, who is a pathologist in our lab and is actually the original author of peritubular capillaritis coming into the Banff criteria. He's very interested in MVI, and we're writing up some of these cases as a case report, and we've been discussing whether it would be worthwhile to go back and do non-HLA antibodies in all of the people that are going to be part of the case series. So perhaps that's a good idea. But I actually think what we've observed in most of the time when we test pre-transplant and then time of biopsy is that in many cases the antibody levels have gone down. And we're not really sure if this is because the immune system is now being very suppressed by the therapies we're giving, or whether the antibodies are being absorbed in the tissue, or any combination of both. We're not sure what that means, but I think many of us feel that when the antibody levels go shooting up, that might be some evidence that they're part of the result or the cause of the MVI. But again, that's an assumption. We don't actually know that.
So I'm going to take one question from Slido, and then for the sake of time, we'll move on, because I think we could talk about this for a long time.
Like 5 years, right?
So for evaluating the correlation of non-HLA testing single antigen bead, what would be the most appropriate corresponding cell-based flow cross-match assay? T and B cells or endothelial cells? What are your thoughts?
Thank you. Yeah, my thoughts on that is that an endothelial cell cross-match would be better, as the majority of these targets are unlikely to be expressed on T and B cells, and also because the protein microarrays that we performed and the analysis that we did was focused on identifying proteins that were expressed on endothelial cells. So that's a quick answer to that.